All right. Welcome, everybody, to Understanding the Opioid Crisis in the Forest City. My name is Jenna Goodhand. I am the director of the Hive London, and I have with me a very special person. Many special people, actually. All of you who are here today are special people. But Claire, who is our intern for this past semester, has probably been in contact with you in some capacity. She has helped us to pull this all together, and she will be joining as a co-host today during this important conversation. Our intention for this afternoon is to not only gain an understanding of the current crisis that we have, but to gain compassion and connection and a sense of an opportunity for prevention and a way in which that we can all move forward together collectively to treat those who are in a space of challenge, and also to be able to identify ways in which we can prevent further harms and challenges. We have brought together an incredible group of people to share with you their stories, their experiences, their ideas, their outlooks. And as we talk today, we will get to have a sense of how this crisis is viewed and experienced through different people. And as part of that, we can go away from this opportunity being better equipped to move forward together. Before we begin today, though, I do want to acknowledge the land that we're on here in southwestern Ontario. I'm assuming that most of you here today are in this region, as the topic today is about the Forest City. The land in which we are on has historically been the traditional territory of the Attawandaron, Anishinaabe, Haudenosaunee, and Lenape people who have this long-standing relationship with our land here, the water and the region. And we have some local communities as well that still share the land with us as settlers, and that is the Chippewas of the Thames First Nation, Oneida Nation of the Thames, and the Munsee Delaware Nation. And I think it's really important, not only today, but in every day, to take time to think about what it really means to be on the land of others, to be settlers in this space, and that acknowledging land is one thing, but showing up and doing the work is another. So today, as we listen, as we share, as we take time together to try and think about community, let's also think of ways in which we as non-Indigenous settlers on this land can be a part of healing, be a part of elevating those voices who have not had the chance to be heard, and be a true part of reconciliation. So with that said, let's all just take a deep breath and let's dig into the topic together. We are going to begin by sort of going through each panelist and gaining a better understanding of what's brought them here today. We do have an additional panelist who will be joining us at 3, Dr. Ken Lee. So at some point in this conversation, a new face will pop up. It is expected, but just to kind of give you the heads up of that, we're not just pulling random attendees up onto the panel. So all of you can sit back, relax, and think about what it is you want to take away from this conversation today. There were some words that came up as we were preparing for this event today, and I thought I would just share those before we jump in so that we can all ask ourselves, you know, what areas of these things do we want to go away with? And those words were education, connection, prevention, compassion, and support. So just taking a moment to sort of think about what is you'd like to go away from this conversation, having more of an awareness about. So yes, to begin, let's go through all of our amazing speakers today. First, we have Brennan Ireland, who is not here in the Forest City today, but he's on a very important mission task experience, and maybe he'll share that with us. But Brennan is Bear Clan of the Oneida Mohawk Nations and was mentored by his grandfather in the ways of the original people. Brennan passes this knowledge on to his 7 children, family, and community. Since 2014, Brennan has been employed as a mental health and addictions counselor with Southwestern Ontario Indigenous Health Access Centre and is a certified Canadian addictions counselor. Since 2017, Brennan has been a Wellbriety trainer with the White Bison Incorporated Colorado Springs in Colorado, USA, and training facilitators in holistic programs to promote Indigenous healing methods and support spiritual healing. Brennan, thank you so much for being with us today. We are so grateful to have you and look forward to hearing your impressions, your ideas, your thoughts. And I will give you the floor to sort of share what has brought you to this conversation and what you would like us to learn from you.
Sugali swagway chate niung gets okwali ni wigi taloto ni da aga ni wagahojot osluni gay Brennan Ireland. So I'm saying hello to everyone. My name is Same Size Bear Clan from Oneida Nation, people of the Standing Stone. So I was approached to be a panelist today regarding the opioid crisis. And what I'll be sharing later is about underlying issues that face Indigenous people, and what is referred to as intergenerational trauma is what we call fear, anger, guilt, and shame. And so with that, that's what's been transmitted to myself. I heard that from my mother, who was in residential school in a mush hole in Six Nations. And also my grandparents, my great-grandparents in Mount Elgin. So this fear, anger, guilt, and shame is a system that is what I would also refer to that is trauma, complex trauma, and it has heavily impacted our communities adversely. And one of the main things that's taken away is our identity. Who am I? Why am I? Where am I going? So that's part of the healing that we're doing, both with myself through SOHAC and also through the Wellbriety movement, and to promote healing and wellness among our people. And so we go to we visit different communities. I work in Chippewa, the Thames First Nations, and I network with the three communities there: the Lenape, the Chippewa, the Three Fires, and also with our own Haudenosaunee 6-member nations. So I hope that's what you take away is the healing from the fear, anger, guilt, and shame. Yawak go.
Thank you, Brennan. Next we have, we will have Katrina Wong. She is back. Amazing. Okay. We have Katrina Wong. She lives, works, plays, and volunteers here in the Forest City, where she has resided for the last 2 decades. Katrina attended both Fanshawe College and University of Western Ontario, and now works in finance for the auto industry. In her spare time, Katrina enjoys reading, writing, learning, and speaking about social issues that impact her community. Most of her time is devoted to her family. Katrina is a proud member of a beautiful blended family, a mom and stepmom to 4 children and a rescued lab, an 80-pound lap dog, actually. Katrina, we are so grateful to have you and would be interested to hear what has brought you to this conversation and what experience you'd like to share with us today.
Thank you so much. You'll notice I'm in a different space now than when we first connected. There was some loud noise going on, so I'm now in my daughter's room. So that's why I look a bit different. I wanted to thank you for so warmly welcoming me to this table to speak today. It is my first time speaking in a public manner about my lived experience, so my voice might shake a little bit. This topic of understanding, thank you, Dean, the opioid crisis is so important to me. And when I was asked about what voice I think is often missing from the conversation, I thought of my own lived experience in my family. I'm the child of a parent who had an opioid addiction. My stepfather was addicted to morphine for almost all of my childhood and part of my adult life as well. He became a morphine addict out of medical necessity. The drugs were legally prescribed by a medical doctor to help him cope with the unbearable pain that he suffered from a head, neck, and spine injury that he obtained on the workplace. I've come to discover as an adult that this experience of mine as his child has perhaps been the one that's shaped my identity most profoundly. As a result of his injuries and dependence, our family was robbed of what could have been our potential. I went from having a stepdad who was a provider in every way to living in a household that felt like it was too full of really big adult issues to have any space for me as a child and my needs. We grew up in poverty in a household that became very abusive. And I feel that the insecurities that I was surrounded by created this magnet inside of me that I had to navigate the world with. And that magnet seemed to pull me towards pain and trauma for most of my life. Eventually, I was able to break free of that and still working on it at nearly 40 years old. I'm very lucky to be able to say that my stepdad was able to free himself of his addiction eventually as I was an adult. But I still require a lot of space from my family to navigate my own trauma. I get to be lucky enough to enjoy a very different relationship with him now than I did growing up. While all of those painful things that I've said are true, what is also true is that my stepdad was also the primary parental figure in my life. He was really important to me. He's the one who took on most of my day-to-day care, as my mom was also suffering from depression and illness and trauma. We were all in survival mode. So despite his addictions and his mood problems, he was a very full person. He wasn't just an addict. I think that the picture that we see in our mind when we try to picture what the opioid crisis is sort of a caricature. It's a character that we imagine that robs us of our ability to feel compassion. And we see someone as a one-dimensional bad person that's made poor choices. My hope is that in being a voice in this conversation, sometimes if you think about this, you'll think of me and my family. And that when we talk about the addict, we understand that they have a family and a story, and their story is usually about trying to cope with trauma and unbearable pain. And that the family that is surrounding them has to navigate their own trauma now and try not to perpetuate this cycle. Our voices need to be heard, and when we talk about healing the person struggling with addiction, we, their family, need to be seen and validated and healed too. So once again, thank you so much for having me here.
Thank you so much for that important introduction and view of the situation, Trina. It takes a lot to be able to share something like that, and I can tell already that even amongst the panelists that I can't see, we're all here with you, and that means a lot. Thank you. Next, we have Dean Anderson. Dean is a passionate Canadian certified addiction counselor, not just an addiction counselor, a passionate one, from London. He currently wears many hats in the addiction and recovery communities, including being a private practice counselor, MAP service provider, consultant, and NRT practitioner. His experience includes withdrawal management, residential treatment, peer support, private care, and several volunteering ventures. His dedication to the field is reflected in the multiple committees, programs, and community events that he attends and participates in. In addition, Dean uses his lived experience to be an advocate for addiction recovery and the removal of stigma through public speaking, media appearances, and educational workshops. Thank you for being here, Dean, in this educational workshop. We are very grateful to have your lived experience and your education with us today. What brought you to this event, and what are you hoping to share?
First, thank you for having me. Thank you for putting on this event. I see that we have a decent list of attendees here today. And secondly, I want to thank Katrina for being the first time sharing that. I got a little teary-eyed when I see somebody sharing a story and touching and reaching out to the public in general for the first time in this magnitude is powerful stuff, and it's really important. Thank you very much. And thank everybody else who is participating. Why am I here? So lived experience, you said it already, that's the main focus of why I got into addiction treatment in the first place and why I got into it, because I saw barriers, I saw areas of opportunity, I saw chances where we could make the system better or help people better, and I saw a calling in that through my own healing and through my own process. In that, I found my way into working in the front line and working in the Salvation Army Center of Hope with the homeless and marginalized populations. And then I found myself running the withdrawal management center there, which is the front line. You can't get any more front line when you're looking at people at their lowest and looking for hope. In that time, I watched a lot of people die, right? There were people, I'm getting choked up myself. I don't talk about this very often. You would watch people come into withdrawal management, and then they would be sick and beaten down, and you'd bring them in and you'd help them, then they would go back out, and then they would find their way back into that again. And you'd see that over and over and over again until you watch them deteriorate over years and eventually die. And nobody deserves that. So I'm here because I'm going to tell everybody that that's not a way to live. And what I want people to get from this is to understand that every person that walked through that door of withdrawal management, they were a result of trauma and mental health. It wasn't bad people. It wasn't people that were deviant or up to no good or had bad morals or making poor choices. There were sick people that wanted to get well. Opioids are a painkiller, an emotional painkiller, physical painkiller. It's also a life taker because it can turn the pain off to the point of taking your life away. And so I'm here because I want to share that. I want to share it with less tears, though, because it's important. And what I would like everybody to take from this is to take the information you get from this and turn it outwards. We all talk amongst ourselves. We're all compassionate people who understand those things that, Jenna talked about: support, compassion, those things that education, understanding, kindness, those things that we all talk about. I think that all the people that are here today are seeing that. We're here because we have those things, and we need to take the stuff that we have and figure out how we're going to point it outwards and how we're going to share that with our families and the people that are not on the call today. And if the 123 people that I see here as attendees right now take that and point it outwards and figure out how they can share it and do something different, maybe we can change their life.
Thank you, Dean. Good group of panelists, eh? It's a good time when you're crying like 30 seconds into something. So our next panelist is Richard O'Connell, and he is I'm gonna read what he has written about himself in his own words. My name is Richard O'Connell. I'm recovered from substance use disorder and decades-old criminal lifestyle. My life journey has taken me from the far north of Manitoba to Vancouver, ending up in the East Hastings area. I moved to London to try a geographical cure in 1988. I worked at a large unionized manufacturing plant here in London until its closure in 2001. Although never fully escaping my substance use, it went full-time upon, feeling like my life was over. I've had issues with coping and stresses in my life, my background and family issues. I'm from an Indigenous family. My father is from the Algonquin Nation of Quebec and was a residential school survivor. I cherished my upbringing and had to reconcile a lot of complicated identity issues to gain my freedom from my old solution of using a very dangerous substance in excess. I've been clinically dead 5 times and spent 6.5 years in prison through my travels. In 2012, I was placed in the London Drug Treatment Court, Diversion Court, and the Care of Addiction Services of Thames Valley. This changed my life. I've been employed since, and I'm sober from all mind-altering substances, including alcohol, for 9.5 years. I'm grateful to be here today to share your journey. Thank you, Richard, so much for being here. Claire and I had the pleasure of talking with you a few weeks ago, and it's so important to have you here to share your lived experience as well. So I will give you some time to share that.
Okay, thank you very much, and I'm very grateful to be asked to participate here and to be on this format today. When I look at this whole opioid crisis, it's this in many ways it's really coming out of the shadows, I think, in the last say 10 or 15 years, and in my experience, it was going on a lot longer than that. Like living in Vancouver, it was an opioid crisis, but it wasn't through pain medication. It was like using heroin. And the people, what I found through my whole journey, people were just trying to cope, and they were trying to find some sense of relief from, whatever it was, with whatever duress that they found themselves in, whether that was psychological, environmental, sociological, and it was seeking that relief, right? And doing that is like wrapping yourself in a warm blanket, and it just takes everything away, you know, including everything, material, everything, and it progresses even worse, right? And like through my whole journey, I kind of swung in and out of the opiate thing, and the I did a lot of other different things too, and kind of mixed it all together, and it was very dangerous. Even dying a couple times wasn't enough, right? Um, so and spending 6 years in prison, I got to meet a lot of people that were into using substances in a very heavy manner, and that's kind of the narrative I always heard. People are just trying to cope, right? And whatever is like, we're hearing a lot about this now, the family traumas and stuff like that, and these fit what I observed then, although I wouldn't have known to frame them in that manner. But it was very obvious. People would talk about intimate things. You get to know people very well on the inside, and everyone had their story, right? And um, like myself, my world existed. I'll give you one good example of something that impacted me very prominently. We moved from London, Ontario, when I was 13 years old, to northern Manitoba. And on the way to northern Manitoba, my dad, who is Algonquin, he informed me and my sister that we were to tell nobody that we were part Aboriginal. Absolutely nobody. So that's kind of how our world went, right? So, and then in hindsight, that was done as a means of protection towards us. And because we didn't find out until, as like fairly recently, my father passed away in 2010 of cancer. And we only found out just recently that he was actually a residential school survivor. We had never known any of that. We knew that our grandmother was, and we knew that some of our relatives have, because we used to spend a lot of time in Kippawa, Quebec every summer when we lived in London. We'd go up for like 2 weeks, 3 weeks a month, and go up on the lakes and stay in cabins. And it was really good, fishing and all that stuff. So this stuff's all coming to light now more. And some things are really coming into a different perspective now of some of the stuff that was kind of going on in our lives, right? And a lot of it was done as a means of protection. And I kind of went on with my life, being dishonest to myself, and that became how I dealt with the outside world in a physical means, even in many areas. And I started addressing this stuff when I was in the London Drug Treatment Court, and started talking about these things. And things started getting better for me just by talking with somebody about them. And it was adding a new perspective to it. Although I don't think really people are telling me what I had to do, or what I should do, or what I should believe, or what I shouldn't believe. They just told me they were happy that I was there. So, I got to talk. It was almost like talking to a sounding board. And we had as much care, whatever level of care that you required for yourself, is how that program worked. There would be some weeks where I'd be there every single day for an hour of one-on-one, and that changed up through the program, right? So I've had a chance to really look at life in a different way. And I will say that like this crisis has taken on like exponential, it's exponentially just accelerated from my observation, and I can look back on it since the more of the prescribed opiates have come out, and that is a big part of this. Is a lot of people were impacted, you know, through physical injuries, and that is a big part of it. But there's also a huge part of it, and it's been touched on already, where people are using these things because they take away emotional pain. They take away the feelings of trauma, of feeling less than. It just takes that all away, and you're able to get through things, right? So, you know, when I started really addressing the underlying problems, you know, I don't, you know, I haven't really been fighting not going back to the substances, right? I'm able to cope. I found some healthy coping skills through my journey, and you know, things have progressed pretty good. So I'm really glad that you know, that these services are available for people, and I try to share what I can publicly or one-on-one with people in all kinds of different formats whenever the opportunity happens to avail itself. So I'm really glad to be here, and hopefully we can touch a few people with this dialogue. Thank you.
Thank you, Richard. We are so grateful that you are still with us today in many ways. Our last panelist, Letitia Mizon from the Nameless in St. Thomas. Thank you so much for being with us today. Can you share a little bit about your background, your experience, and maybe what the Nameless is for those who haven't heard of it before?
Yeah, thanks for having me. First and foremost, I really appreciate being here and being able to talk with an incredible panelist as well. So I'm really grateful. What the Nameless is we're a bunch of screaming possums. That's how I like to describe us. We're a bunch of community members, peer-based is kind of where we do our work. We are a volunteer organization in St. Thomas that focuses on harm reduction first and foremost, and then rapid mutual aid after that. We're just a bunch of people who've come together to recognize the power within each other and the talents that we all have, that we can, as a community, as a collective, come together and meet those needs in a rapid fashion. It basically dismantles the fact that you need to have alphabet soup behind your name to make an actual change in people's lives. And so that's kind of a bit about what we do. Yeah, it's pretty interesting. We kind of started from a trunk, then we went to a shed, and then we moved to a brick and mortar. And now we have another brick and mortar downtown St. Thomas, where we're open on volunteer hours from 6:30 to 9:30, 7 days a week. We also have 2 outreach teams that go in community and meet people where they're at. And that's kind of what we do. Yeah, so thanks for having me.
Wonderful. So for participants here today, the funds that we have been raising will be divided amongst the Nameless and SOHAC, which is where Brennan works. So Brennan, I don't know if you want to share just a quick little bit about what SOHAC does, so people know sort of where the funds are going.
Yeah, so SOHAC was started to provide safe care to Indigenous people. As we were talking about, our people were being turned away in healthcare settings. And so SOHAC was developed to support our medical needs. And then it morphed into more things like mental health and addictions. So we have doctors, nurses, a clinician. We also have traditional healers as well. So to the best of our ability, we're trying to unite those services, both Western and Indigenous, to provide the clients with holistic care.
Beautiful. Thank you. If you haven't donated and you'd like to donate, I'll just put in the side chat there, and you can do it now or later. I'm going to now pass it over to Claire, who is going to move us to the next question.
Okay. Thank you so much, Jenna. And again, thank you to everyone for being here. This is a really important topic for me to talk about, and especially just learn more about. I've been working downtown London for the last 8 years, and it is an issue that's in the public eye that way, but I also recognize this is an issue that not everyone can see, and it needs to be addressed. It's important, and it's part of our community. So thank you again, everyone, for being here. Like Jenna mentioned, our intention for this event is to leave with a better understanding of opioid use and addiction from various perspectives and experiences. So my next question is, are there certain experiences or challenges you've had personally or professionally that show a lack of understanding or appropriate support for those affected by opioid addiction or addiction in general? Is there someone who would like to answer first? Dean, please go ahead.
Myself, as soon as I unmute myself, I will talk. Brendan made mention to marginalized people not being able to find proper health care, being turned away at the door. I would see people in withdrawal management come in the homeless population who were genuinely sick, had abscessed, had things that were going on that were potentially fatal. Even one time I had a gentleman with lung cancer, and he went into the hospital and was assumed that he was drug seeking, and he went there 4 times in a row saying, "There's something wrong with me, you have to look at me," and he got turned away each time. And it wasn't until he finally demanded and refused to leave the ER that they took him in and scanned him to find out that his cancer had gone so far that it was terminal and there was nothing else they could do. Meanwhile, he had been in there over and over and over again trying to get those services. And I see how that happens in these frontline spaces like Emerge, where they get taken advantage of, or people come in and they are drug seeking, or maybe they just want a home, or are looking for a place to sleep or get something to eat. But it's that lumping everybody into that same category and making those assumptions, and then that's when people really get hurt and fall through the cracks, and it's dangerous as all get out. And we need to look at the humanitarian side of things and just saying, you know what, we need to assume everybody's telling the truth when it comes to care and humanity, right? I like the way it was said. Letitia said, you don't need an alphabet soup after your name to help people, right? And we have that opportunity right across the board to just be there and help people and help them find what access is. And if it's not, medical care in the street, then it's, maybe it's finding the way to SOHAC or find them house to alternative medical care or whatever. But that's what I see that's disturbing on a regular basis.
Thank you so much, Dean. I really like what you said about making assumptions, and just like the power of making an assumption and that carrying through, and the effect that can have on people is so great. Thank you for mentioning that. Is there someone who would like to approach the question next?
I'm happy to touch on what Dean was talking about regarding drug-seeking behavior. So I've seen a lot regarding the back work that it takes for people to get even into the doors of an ER. The weeks of begging and talking to them and being like, yo, you're gonna get septic, you're on death's doorstep, you need to go seek treatment and help medically. So basically, we need not to send people away because we have the perception that they're drug seeking. We don't need to make them wait hours long in a ER room because we think as healthcare providers that they're drug seeking. We don't need to enforce them to go unmedicated during painful procedures because, again, we think that they're drug seeking. We need to look at it at the forefront and say, okay, you're here for a reason. Let's navigate that reason. Let's figure out what that reason is, and let's work on that together. I think it's really important that we recognize that, the work being put into somebody to go get medical treatment is huge. And on their side too, the preparation, the frontline support being like, yep, you need to go get help. Let's walk in and look at that arm. I think we need to reduce stigma at the ER and the healthcare centers and be able to encourage people to go get the help that they need.
Thank you so much, Letitia. Would anyone else like to touch on the question at all?
I think Richard had his hand raised, but he's still muted. You know, Richard, we really want to hear what you have to say.
Yeah.
Okay, am I unmuted muted now?
Yeah, you're all good.
Okay, yeah. Yeah, everybody touched on some really good things here, and Brandon kind of let it off with access to healthcare, and I just wanted to share that the London Drug Treatment Court program was designed almost exclusively focused on the healthcare of the participants, and people were allowed very, very quick access to just about any form of healthcare services. And that was all facilitated through the treatment side of the diversion court program, which was Addiction Services of Thames Valley. And they made all the logistics possible for the participants to get in to see physical, even like into the emergency rooms, into seeing a specialist for different physical ailments or for mental health, all different kinds of things. And that was the beauty of that program, because it was based on through harm reduction, not through judgment or mandatory abstinence. That wasn't part of the program. It was about participation, showing up to your appointments, and that was the essence of the program. So just through that experience and watching, not only myself, but I mean, watching all of my friends, I consider them my friends that I went through that program with. There was only 8 of us. It was just a small pilot project then. They didn't even have funding yet. They were doing it on their own funding and through actually volunteering their time, the crowns, the judges, everyone. And I watched how addiction was not really about substances. It was about many other different things that were underlying, right? And they were allowed to gain the access that I heard this story from many, many people. They couldn't access the services that they probably required until they came into the drug treatment court program. And everybody's made huge lifestyle changes, whether they're abstinent or not. That's not the point. They have gained access back to their family, their children, all kinds of beautiful things, right? And I'm still in contact with a lot of them now, and everyone's like they've managed to build a life for themselves, all because of this small pilot project where it started, right? So I'm really hoping for the reopening of the drug court, which sadly was closed about 5 years ago, but apparently it's back on board, and they're just waiting for the COVID crisis to get over, and they're going to be back on. So I'm really looking forward to that coming back for our community and for the people. Thanks.
Thank you so much for sharing that, Richard. It's so great to have you on this panel and be able to hear your personal experience with all of this as well. So thank you so much for sharing just your life and your life journey on that. Katrina, I'm wondering, is there any experiences or challenges that you've had due to the lack of understanding or gaps in support for your family that you experienced?
Absolutely. Thank you for asking. So I'll kind of speak to that I guess from a very different lens. The way that addiction impacted our family is so complex, and at the time that we were going through it, I would not have been aware of any of the needs that I had that weren't being met. It's sort of what I can provide looking backwards. I was one of 6 children, and one of 6. And, you know, the family dynamics impacted all of us in a negative way. I think that it wasn't quite as visible, the things that we were lacking and needing, as it can be with the person who's addicted themselves. It can be very visible. With us children, it sort of looked very different. You know, we could have gotten in a lot less trouble. We could have been in less dangerous situations. I myself was a very quiet, very agreeable child, so I didn't have any behavior issues that would have drawn attention to the things that I was needing and lacking. I was also a teen mom. I had my first child when I was 14. So, you know, there are ways that it became visible later on. When children are being cared for by parents that are experiencing addiction, their needs are not being met. There are necessarily things that need to be provided that are not being provided. And for our household, a lot of that was emotional. It was very complex because our immediate shelter and food needs were being met. But there were resources that I feel could have been offered if people had been maybe bold enough to say, we understand that there's addiction going on with the parents in this household. These children definitely need some resources. Therapy would have been at the top of the list. We all needed therapy, but didn't know it. Mental health support, even with knowing that our shelter and immediate food needs were being met, having access to nutritious food would have been really great for our physical and mental development. Recreation opportunities, because we, you know, didn't have a lot of resources. If someone had maybe taken us kids and said, you know what, here are some supervised, safe recreation resources where you're connecting with other children and seeing maybe that the things that we've gotten accustomed to feeling are normal, they might be normal in our household, but they're not healthy. And you can have this other experience as well. Most of all, I think that having an adult, any grown-up that was trusted, anyone, had anyone come and said, you know, to me as a child, things are tumultuous at home and it's not your fault. Things don't feel good right now, and that's not healthy. You don't deserve to be impacted by these negative feelings. No one said anything, and there were lots of people who knew, you know, that we were being impacted by this. So I think it's, you know, being bold enough to sometimes insinuate yourself in a situation where you know that children are being impacted, and giving non-threatening help. You know, ripping me away from my family wouldn't have helped. But there was a lot that could have been provided to have made our lives a little bit easier. I hope that helps.
Yes. Yes. Go ahead, Brennan.
So I just wanted to share on that as well. So one of our barriers is to take a person from a state of, I don't know what I don't know, what to change. And when we provide information and teachings, now I know what I didn't know. So what often happens with those that work with Indigenous or addictions in general is the root issues. And those root issues of fear, anger, guilt, and shame have been normalized. So some people don't know that that's not normal. So the biggest barrier we see in our communities is child abuse, physical, mental, sexual. So when individuals, that's their cycle of life, that's their norm, that cycles into the next generation unless it's stopped. And how it becomes stopped is to know what you don't know. If that's abnormal, that's not normal. And then due to the oppression, our people are fearful of our way of life, our teachings, our ceremonies. And so because of so for example, my mother, she's a fluent speaker, but never spoke it to us because of the abuse and all those things that cycle in. So myself, although I was being abused every which way, that was normal. Everybody's abused, not knowing that that wasn't abnormal. So that was the big barrier. And that's also my barrier is a counselor and support system is helping people to realize what they don't know, that abuse is not normal. That fear, anger, guilt, and shame, because that's what they continue. And then their kids inherit that, just like our speaker had just shared. And that cycle is so difficult to break especially when it's multi-generational. It goes back, we'll say 7 generations, but even 3 that I can recall. So stopping that cycle. And So again, addictions, self-medicating to numb that pain, and then uh, what that fear system looks like are characteristics. So there's no trust, there's dependence, there's codependence, there's shame, there's guilt, there's no identity. So it's pretty overwhelming system to help an individual overcome. It may not happen in a 30-day treatment program, but we start that process and help that person through that. And we want to be any door's the right door to start that conversation. So that's basically how I work, but I get a lot of help as too. It's a lot of work to provide that support. So we work as a team as well with the elders, with the medical team, with the other social workers. I'm not a social worker myself, no alphabet, but what I have is I've been pretty fortunate. My grandfather was hidden out, so he didn't go to residential school. That's how I'm able to speak my language, and I know the ceremonies. So know the pathway to the love system. That's the creator system, and so that's what we're working on with our community. Is so, for example, that's one of the first things I hear is I want to be loved. So we ask, what is love? And there's really no real responses. So we help them to connect to that love system when we provide that. So in essence, we're almost like their parent coming back um, to that healthy development. So I thought I'd share that. Thanks for listening.
Okay. Thank you so much, Brennan, for talking about that. It's so important to talk about the people that experience addiction, but also the family that goes through the person experiencing an addiction, because it's just such a whole different realm in both of them. So thank you so much, Katrina and Brennan, for speaking on that. Jenna, do you want to ask the next question?
I'll just mention that Richard had to go to work, and so he's left the conversation, but we'll be sure to follow up with him. Language is so important. How we talk about this topic, how we talk about each other, how we talk about ourselves. Stereotypes are very influential in terms of how people have access to compassion and connection and community, and all of those support systems that are really missing. Are there certain beliefs or stereotypes or language that is commonly used by those who don't have a deeper understanding? So, myself included, those who are here today who want to do better, who want to be better, who want to be allies in conversations when they hear someone talking poorly. What are some things that you have recognized that are barriers to those deeper approaches of connection and love and care? Anything kind of under that umbrella that has come up for you or that you think is important to share?
I'd be more than happy to jump in here, no problem. So being engaging with community members, we hear a lot of harmful words. Usually people who are hurt want to hurt others, and they'll use their words to get through to them. And usually this is on social media. But just like two topics that I'd like to cover here. One would be forcing treatment and tough love, the idea of tough love. This is one that's highly problematic, as taking away power and autonomy for an individual who has little to nothing left of a support network or self-esteem or self-worth. Power and choice are two very protected things for them. They hold that very close. Forcing their hand at something so impactful for them and the struggles that they endure day to day, taking away the only piece that they have is a big whopping no. We don't force people to do things. We encourage them, we support them, we walk hand in hand with them, beside them, to make those choices, to empower that decision. The pain that they endure at the hands of the system built to protect them, the wait lists that they face, the inability to navigate even low barrier programs, never mind the high barrier programs. What we need to do is incorporate tolerance and harm reduction and be there for people to ensure that they are there at the end of the day for when they choose to make that next step. We need to build them up. We need to empower them. We need to make them feel worthy enough of the treatments and the opportunities in front of them. We need to also be able to have a wide variety of care at the beginning without any wait lists. A wide variety of supports there when they do come out of detox, incarceration, hospital, or treatment, to be able to support them moving through that life-changing transition without expecting change in the original environment. Far too often people come out of detox and then thrown right back into experiencing homelessness, and we expect change as a community. That's not how we need to do it. We need to have those services available for them when they come up. Secondary piece here, and this is really important, and I've heard this a lot, is why is Narcan free and diabetics don't get care, or EpiPens are considered, a thing for free. Simply put, pitting those who are struggling against those who are struggling is stigma and will kill people. We need to not decide as a community who is more important of medical support, services, care, supply, and medicine. We need to do better for everybody as a whole and not increase the hate and stigma because one population has something that the other perceives is owed to them. Learn about what's available in your community. Many, many communities have diabetic clinics that will offer nutritional information, support, tools. Needle exchange programs will offer 1cc syringes, no problem for people, navigating diabetes and needing to take insulin. There's also grants that'll cover medication like Chilium healthcare benefit for those who are struggling to pay for their medical needs. How many times do we need to Narcan someone? As many as it takes. We need to be there and make sure that they have access to the life-saving medication if they experience a poisoning, without question, each and every time. Each and every life is worth saving, and if you're thinking differently or are led to believe otherwise, you need to check what's in your Kool-Aid, because you're drinking it and it's wrong. And we need to encourage people to be able to be there each and every time without fail, without getting tired, because people's lives are worth it.
Thank you. That was fantastic. I'm looking forward to watching the recording, listening to that series of statements again. Brennan, did you have a comment to add to that about language?
I can add something about language.
Sure.
So we see it all the time where it's just, Brennan had said something about, multiple times talking about guilt and shame. And guilt and shame is the root of it all. Shame being an emotion that's, inflicted inward, saying, I'm not good enough, I'm not enough, I'm not lovable, people don't care about me. And when our language and dialogue that we use each day refers to the lower echelon of society as a crackhead or a junkie, and even when people are just making fun of somebody, say, what are you on, crack, right? I mean, that's the joke to say to somebody else. So we automatically take that and we put them into the lower echelon of people, and really these are sick people, right? We're not saying like, what are you, diabetic, right? I mean, think about how crazy that would be for us to say that about any other marginalized population, and that's what we do. So this language that we use, even addict, and alcoholic. I mean, these are assuming that person is nothing but their disease, right? And it's a person with an addiction. It's a person with alcoholism. It's a person with an addiction or substance use disorder. You're not an addict, right? You're not that person. You're not a junkie. You're not those things. And that just, feeds that underlying understanding, and not just, Letitia said, the people in the front line hurt people. It's not just there. I mean, it's people walking down the street. It happened to me last weekend. I was standing there with a friend of mine and said, all these crackheads over here. And I'm like, what are you talking about, right? What crackheads, right? And it's just a derogatory term to say that, these lowlifes is their word of saying it. And it's just not okay. And we have an opportunity as a society to, when we hear that or when we hear those words, to just turn around and say, oh, that sick person over there, the person that needs help over there, not that, labelizing stigma that we put on top of it. And that, is what prevents people from getting care in the first place. I want to touch back really fast. We were talking earlier about the medical barriers. I've had people standing in front of me that have lethal medical concerns, and they're crying because they don't want to deal with the shame, because they get called these names by professionals in ER rooms that have a code of ethics, police that swear by an oath on a code of ethics, talking to them in a certain way. That language has got to stop in a professional way, and it's got to stop in the streets. And we have to figure out how we're going to figure out to start using the language of sickness, illness, people that need help. Thanks.
Thank you, Dean. Brennan or Katrina, did you have anything you wanted to add to that? Brennan?
Yes. Yeah, so similar to what Dean was saying, that negative self-talk that individuals inherit due to that, the fear, anger, guilt, and shame. So there's fear and anger, guilt, shame throwers, and then there's catchers. So what would change now is not giving those throwers the power to tell you who you are. Who am I? Why am I? Where am I going? And so with that becomes their self-talk is an addict, and their self-image. This is who I think I am. And whenever they try to change that, they're visited by attention system, anxiety, stress. Just like Dean was saying, you go to these services, this is what they see of me, and this will prevent me from getting the services that are much needed and I deserve. So it's changing that self-talk, and how we do that is by envisioning who I am. And so we change that self-talk, build that self-esteem up for the individual, and that's what we also help do as advocates, and support them and go with them to their appointments. And sometimes that's necessary until they get independent, right? That's what that's the goal, is independence, not dependence. And so what we're trying to change others too, and through this conference here, is their beliefs, their attitudes, their habits, and their expectations. And so when people view people as differently, you have to work at it habitually to say that. Just like Dean was mentioning, seeing people is people that are have an illness, as opposed to a negative derogatory, because a lot of times that's about the person to boast their ego about themselves. That's not love. And so that's some of the languaging we see as far as stereotypes and stigma.
Thank you. Katrina, your experience is, hidden almost, right? As a family member, are there things that you have heard over the years, or ways in which you have felt that stereotypes or language have affected you personally, or anything in that sort of realm?
Absolutely. I think I used the word caricature earlier, but I find that often when we're speaking about people who suffer addictions, and I believe it was Dean who just said that this isn't an addict, it's a person. This is a human being with a full life and a full story outside of their addiction. When we think of what that looks like, and I find especially right now with the opiate crisis, we tend to, lots of people tend to really boil it down to that pesky crackhead on the corner that's, ruining my storefront and littering on the sidewalk. And when we reduce someone to that one-dimensional, thing, it becomes very easy to turn away and say, I don't need to offer this person compassion. They're just going to make bad choices. They chose this life. They need to just work harder and get out of it. And when I hear people speak about people suffering addiction in that manner, it does make me really angry, because I think that the speaker lacks an understanding of how choice works in the brain, and how that's impacted by the trauma that they've been through and the way that they're coping with it. So I really dislike when people throw the word choice and they've chosen this and they need to make better choices. Of course, people have to be responsible for their choices, but it's not just that simple. I think that us as family members, especially the children of those with addictions, we go through life taking on a lot of that trauma that we've been exposed to and that's been imposed on us. And it's now us that have to navigate the world, struggling to make our own good choices and trying desperately not to become addicted to things ourselves, trying to break that cycle. And we didn't choose this either. we all have these really complex needs that have to be met in order to break the cycle. And we can't achieve that if no one's willing to, give a hand up with a little bit of compassion and, recognizing you're a full human being. This is one little slice of the pizza that is your existence. And we're not going to reduce you to that thing. We're going to help you, realize the rest of your potential.
Wonderful, thank you. And right on time, Dr. Kenley has joined us. Welcome, Ken, to the conversation. We're going to pull you right into the question and the topic that we're chatting about, but first I'm just going to introduce you. So Dr. Lee is the medical director of the Rapid Access Addiction Medicine Clinic here in London. The RAM Clinic offers community-based, low-barrier services for clients seeking treatment for any substance use disorder. It focuses on addiction medicine and offers both medication and psychosocial interventions and community education about addiction medicine for healthcare professionals. Welcome, Ken. We're so grateful to have you in conversation with us today.
Thanks for the invitation, Jenna.
Yeah, so we've been talking about a lot of things. We are just sort of leaving a conversation about the effects of language and stereotypes, and obviously it's come up a lot about trauma and how that plays a role in challenges with addiction and use of opioids. What I think would be very helpful is if you could help us understand what's actually taking place in the brain as people are using opioids. What would someone's brain be experiencing maybe the first time they use opioids or ongoing, so we can kind of bring together all of this information from both a physical and an emotional and mental experience.
Sure, I'll just try to cover some of the highlights. What's interesting about addictions, and it doesn't matter what the substance is, whether it's alcohol or cocaine, stimulants, crystal meth, fentanyl, or opiates. Roughly in history, historically, and in the general population, which it still holds today, about 10% of the general population in any society is at risk for developing an addiction. So specifically speaking about chemical addictions, this, historically, you could look at opiates years ago, cocaine, whether it's alcohol, way back, if you look into historical records, and it still holds today, about 10% of the population. So in order to develop a chemical addiction in your brain, you have to have, firstly, the susceptibility to do that. Part of it's genetic and part of it's your environment. Roughly, it's difficult to quantify, but roughly 50% of it is genetic. So for example, if you look at alcohol, if you have one parent who's struggles with alcohol, let's call it an alcoholic parent, you're going to have a risk of about 50% of having the same problem yourself. If you have two parents that struggle with alcohol, your risk yourself is about 70%. So you can't beat genetics. Your genetics is what your genetics is going to be. But if you recognize some of those factors, then you may choose not to expose yourself to certain things. If you look at opiates today, going back to the 90s when OxyContin was widely available and prescribed, about 10% of people who were exposed to Percocet, OxyContin could get addicted to opiates. And these are people who are exposed in any way, whether it's doctor prescribed, post-operative pain control, or recreational use. About 1 in 10 people will get addicted. 9 in 10 can just take it or leave it, decide to stop when they choose to stop. In terms of opiates per se, what happens in your brain is that if you're exposed to opiates and you're at risk, the feeling of euphoria that you get with opiates is so overwhelmingly pleasant that it's very, very easy to want to have that. People describe it as being wrapped in a blanket, there's no problem in the world that matters anymore. You just feel good. And some people do that for various reasons. You may do that because of trauma you've been exposed to in the past. You may do that because you need some escapism from your life circumstances, whatever they may be. Alcohol is a similar type of effect. It does affect a different receptor. Opiates affect the opiate receptor. Scientifically, there are 3 or 4 of them described, but the most important one for opiates is called the mu receptor. And they're labeled with these, I think they're Greek alphabet letters, similar to the COVID virus, you know, alpha, beta, gamma. And I think the mu receptors are the opiate receptor, which is the main concern. With alcohol, alcohol deals with a different receptor. Alcohol deals with basically the receptors are related to similar to gabapentin receptors, GABA receptors. If you're talking about stimulants like cocaine and crystal meth, you're talking the dopamine receptors. And dopamine is the medication that, not the medication, dopamine is the chemical in your brain that makes you feel good. So that's a little bit of the background. It's more complicated than that, but that's the simple version.
Thank you. So in a minute, we also would love to hear sort of, there's some groundbreaking results with something called Suboxone, I believe, that you've been working with that helps to block those opioid receptors. So we'll kind of loop back there, but Claire, I wondered if we wanted to open up the next question, and then Dr. Lee, we can kind of bring you into the mix as well.
Sure. Thanks, Jenna. So our next question is, how do you think individuals and organizations can be a part of prevention and/or better support for those who are struggling? So what's missing, or how would you go about solving this challenge? So someone like that would like to approach the question first. Dean, please go ahead.
You want me to go?
Yep.
Okay. When, you know, Dr. Lee just said it, you know, 1 in 10. If this was 1 in 10 in any other thing, any other substance, any other whatever, any other type of disease, then we would have more knowledge and information just in the general public through the education system, through the things that we do every day, work related, the billions of dollars that, you know, our economy loses every day in work related injuries and loss of income and companies that pay for that. When we look at all of those impacts it has right across the board, we have an opportunity to start making this part of workplace information and about how to understand and see these things. We have all of these different theories, and you know, Dr. Lee said it again, you know, there's a genetics, and then there's an environment. You know, there's a dozen different theories of how addiction comes about, trauma, whatever. But there's only one way of preventing that, and that's through education and knowledge, and knowing that you can find help, and knowing that we can change, you know, societal structures to be more empathetic towards that. We can't scan everybody's brain and say, oh, you're susceptible here, take this pill that's not going to make you get addiction in the future, right? We can't do that, but we can provide awareness and understanding so that people can say it's normal. And Katrina said something about it earlier about, you know, just opening up those doors to say it's okay to ask for help. It's okay to, reach out and ask for these things. And I think we're not looking at anything that's going to change tomorrow. But I think it's a generational thing. I think if we start doing that, then in a generation from now, we will have changed the way that we look at it, the way we treat it, the way that we stigmatize it. Thanks.
Yeah, well said, Dean.
Thanks.
You know, 1 in 10 is a huge number, right? So, you know, if 1 in 10 people got cancer, actually that may be true. If 1 in 10 people would break their leg, you know, certainly we would invest the resources into to treating that. And really, the medical system doesn't need to look at addictions any different than any other medical condition, right? So if we have some things that we can do medically, we should do them, and we should offer them. And when you look at the resources provided to addiction treatment and resources, whether it's rehab, RAM clinics, you know, whatever, I think we only get like 0.1 to 0.5% of the healthcare budget. And if you look at opiate overdose deaths compared to COVID deaths, and the amount of resources put into dealing with COVID, more people have died of opiate overdose than have died from COVID, you know. Um, and I would submit that the suffering is very much similar. So it's a matter of priority. It depends on what society and we as a collective society want to prioritize in terms of treatment. We need to normalize treatments and not make it different. If you had a broken leg, you'd go to the hospital, you get it treated. If you have an addiction, then you go to whatever we're using, whether it's a rehab or addiction clinic or counseling, whatever, you just go get help for it. It should be as simple as that.
Yeah, thank you so much. I'm wondering, Brennan, are there alternative approaches to medicine that you would use in your community that you'd like to share at all?
Yes. So as far as prevention, that would be stopping the cycle of the fear system. And how we do that is the individual gets well, and what happens, the family gets well, and then the community gets well. We call that a healthy forest. And there's four gifts that help us to attain that, and that is hope. Principle of hope. I want to move towards and become like that which I think about, which is a vision. I envision this healthy community, my healthy family, being healthy individual. Healing, not just the individual, but the family and the community. And unity. So we're unifying. We're seeing a lot of negativity as far as that goes. And then forgiving the unforgivable. And that's a huge one that our elders are teaching us about, is to forgive, and those that have done a lot of damage to our life cycles for generations, for over 500 years. And so with that, when that forgiveness happens, it frees that person, and then it also frees their children. So the next generation, so they're not inheriting fear, anger, guilt, and shame. That's not being transmitted. And how we do that is with our medicines. So I'll just briefly say, so we do a welcoming ceremony. So really quickly, I would say, and I'd be welcoming, and I've done that with my seven, and I'm welcoming them to this world in a good way. They're hearing the language, and those are the barriers that have happened with our people. So they're of one mind with all spirits of the earth, starting with the people, our mother, the earth, and all the way up through sky world to the creator, Sagwayandism. So that's what we call prevention. And it's not forced on anyone as well. It's on a want to, choose to, like it, love it basis. And so when we bring it about that way, for example, my own children who are in their mid 20s who've never touched drugs or alcohol, so that trauma has stopped, and their kids won't see that fear, anger, guilt, and shame. So that's how we do it. We do it with the songs, with the medicine. And again, that's what was disrupted, heavily disrupted. That's an understatement to our indigenous people, both in the United States and in Canada, and through that system of oppression in residential schools. So it stopped our people from practicing and speaking the language. And that's what's coming to the forefront now. And more people are becoming aware. So this awakening is happening. And people are seeing the truth, and what we've known for quite a while. But through that is this move towards our children becoming well. They're not carrying that negativity, so they can be whoever they want. We have two-row wampum. Ours is the canoe. The Europeans is the boat. And we do our best to stay in our canoe, and but in friendship as well. It's we're unified, and that's where we're coming. We need all people to unify. the four directions, the four color of man, but we're one human race. Thank you for listening.
Thank you so much, Brennan, and talking on the importance of unity as well as part of the medicine and as part of the healing, and the important part that unity and coming together plays. Thank you. Thank you so much. Letitia, I'm going to extend the question to you again of how do you think individuals or organizations can be a part of the prevention or better support for people that are struggling?
Thank you. So basically, we as community members, we have a lot of power. We hold the majority of the power. So we need to use that to the best of our abilities. How can we do that? We can have conversations with our children that are honest and at their level, that come from a lens of education and not fear. We need to learn what community resources are available to refer individuals to it, like your neighbor. Your neighbor's struggling and screaming out in their lawn. You're gonna have a conversation with them and be like, hey, I don't, have you tried this? Maybe be more equipped to have those conversations with community members. Learn de-escalation techniques that don't involve a call to police, because we know that marginalized communities are more highly susceptible to police violence. We as community members with privilege, with our white privilege, we need to access that and use that to our advantage to do good instead of doing harm. We can learn who is in your community. What are their names? What are their stories? Are they willing to talk to us? They don't owe us anything, but if we can have conversation, we can create those connections with people, which are so, so important. We can write letters to levels of government and petitions, and we can have that power behind us as well. Pick up some garbage in your community. Literally, it takes 3 minutes to pick up some garbage. Instead of complaining about it online, let's do something about that. It's easy. Learn how to pick up sharps in your community. This is a huge issue that we're having in both St. Thomas and London. Learn how to do it. It's really simple, and there are plenty of people who can teach you how to do it properly to keep everybody safe. Make phone calls to your MPs and program directors. Seek out grassroots groups who have been working on the front lines and offer help. It's been incredibly hard, this pandemic, to not only be a community member, but be a grassroots organization who is community funded, who is just, navigating this crisis with your neighbors. Look up who is in your community and who is doing that work and support them with a like, a share, a financial donation, even reach out to them and be like, I see you, I see the work you're doing, and it's really important. Thank you. You can, what else can you do? Learn how to recognize the signs of overdose. Learn how to, learn how to administer naloxone. Learn how to have a conversation with somebody who's lying in the middle of the sidewalk. Like we just had that article come out that people were just passing by. Learn, why is that man laying on the sidewalk and what can I do to help? Carry and learn how to use naloxone. It's really important. It will save a life. Ensure that there's a safe consumption in your facility, safe consumption facility in your community. Support safe consumption. It saves lives. There are too many people dying of, overdose, of soft tissue damage, of HIV. We need to have these supports in community, which not only support them exactly where they are in a non-judgmental fashion, but are able to refer to other programs that offer medical treatment, connection, housing, like a whole plethora of things that can help them holistically. And it starts at the grassroots, at the harm reduction heart of it, and support safe consumption facilities in your community. Volunteer in your community with vulnerable populations, not to gawk, but to learn who is in your community and learn their names, and be a support, because you never know, like the 30 seconds that you get to have an interaction with someone, you can improve their lives. Just seeing them as a human instead of a person who's accessing services, or that person who's laying and creating garbage in my community. Have a conversation. Be open to change. And should you find yourself at a table that talks about policy, procedure, new programs, look around. Take a look at who is at that table and get people with lived experience on that table, and give up your space for those people to be at those tables, because it is so important to have lived and living experiences help shape your program the way that they would benefit from it. Because at the end of the day, they're the ones who are navigating these programs, not us who live in a house with access to ID and can hop on a bus at any time. We need to have people who have experienced those barriers to be able to shape our programs a lot more better and more efficiently. What else? Hold programs accountable for outcomes. We have these programs in our community that say, we do this. This is our goal. So hold those programs accountable. Ask them, hey, I saw that your outcomes or your projected outcomes are, we want to have 40 people housed. Where are you at with that? Or we're a low barrier service. Can you talk more about that? So holding programs that are really, really incredibly highly funded accountable for their outcomes. And access to culture. I mean, Brennan said it right there. Access to culture is such a huge gap that we have in our community. We need to encourage people to seek their roots and their culture and have spaces where people can access that. So thank you for listening.
Thank you so much, Letitia. I think a huge part about what you were talking about too is just having that conversation. That's a huge way to break down stigma and barriers. And thank you so much for pointing that out. Katrina, is there anything that you'd like to add to the conversation?
Yeah, thank you. Again, I'll kind of be, speaking to this from a slightly different perspective. And it's such a complex problem. I don't have like the solutions, but I can definitely recommend some things that I think are needed to support individuals that are being traumatized by addiction. It unfortunately all boils down to funding and resources and the need for there to be more resources. As I mentioned, I was a teenager who was a single mom, and I lived on my own with my first son. We grew up together. I was 14 when I found out I was pregnant with him. It could have and should have been a situation that turned out worse than it did. I was lucky that a handful of really great, empathetic people helped me connect to resources that I needed very badly to break those cycles. I didn't want to be abusive to my son. I didn't want to neglect his needs. And I certainly didn't want to battle any addictions of my own. And I could not have achieved those goals without lots and lots and lots of social resources. I think that when a family is being traumatized by addiction, early intervention is extremely important. And when we know that an individual is struggling with addiction and they have a family, it must be assumed that the entire family needs those resources. Treating children of opioid addicted individuals as if you know that you must prevent addiction in them, because it's a road that there's a recipe brewing inside of us that could very quickly, very easily lead us down that road. The children need nurturing, therapy, opportunities to play safely. And again, I mentioned this earlier, but they need to know that even though this is normal at their home, this is not healthy and they don't deserve it. And with the help of those resources can hope to achieve a very different outcome for their lives. And we need to understand that the family members and the children are not responsible for asking for the help that they need, because we don't know what it is. I'm almost 40 and I'm still figuring out some of the helps that I need to maintain, this life that I've created for myself. Resources have to be made available to us, and the burden of figuring those out can't fall on those kids. We have to be very mindful about understanding that the needs for overcoming these very complex issues, we have to be intentional about our thought process. We have to be intentional about how we think about people with addictions and their children and the people that walk away traumatized because they're, in the addicted person's peripheral life. We have to assume that that the whole, you know, very holistically, the whole family, the whole community around this person, you know, needs that trauma support.
Thank you, Katrina.
Thanks.
Dr. Lee, as we've been hearing, you know, there's a need for facilities, for support, for resources. As someone who has spent a large, you know, chunk of time in your life in these sort of facilities, helping, what can you provide in terms of your own insight, or even what's on the horizon, or is there any hope that you can add to some of these challenges that we're facing? Please.
The one thing I would mention, which would make it easier for people to get help, would be I've noticed that a lot of agencies, whether it's hospitals or addiction services organizations, even our organization, ADSTV, or rehab facilities, etc., is that there seems to be an inordinate amount of intake paperwork and assessment that is required before someone can be accepted into a treatment program. So one of the biggest barriers I see is doing that gains survey before people can get in. Because I got to tell you, I have worked in an addiction facilities inpatient unit. It requires a gains before you get in. No one looks at it. It is a statistical gathering instrument that funders require to show some kind of statistical benefit. We do it a little bit differently at the RAM clinic. We will see people very quickly. We overcome a lot of the paperwork and a lot of the assessments and such. And, you know, maybe we get that done over a period of time and not that first day that people come in, or even that first week or month. So that's what I would say. There is a lot of administrative barriers to getting people into treatment. And if you could just get rid of that and just simplify the intake process into getting treatment, whatever form that may be, that would be the biggest thing that we could do. And it would save so much staff time doing these things that they could concentrate their time on providing the service as opposed to collecting statistics. Yes, I see that, you know, people have mentioned that you need performance measures and all that, but you can get that in a different way.
I would love to second that. So those of you who don't know what Dr. Lee's talking about, it's a global assessment of individual needs. It's a questionnaire that you would ask somebody who's in active addiction who is coming and looking for treatment, and it can take up to an hour and a half of you asking them multiple choice questions about very personable traumatic experiences and things that have happened in their life, and it's normally asked of somebody who doesn't really know the person that well yet because they're trying to get access to treatment. So you haven't built rapport yet. You haven't built security and safety. And here you are saying, sit down, I'm going to ask you these, you know, questions. And then that progressive care is determinant on all that paperwork and all that stuff to get that. So in withdrawal management, we would perform the gains process with people, but then they would come in, and then the waiting time between that service and getting into another treatment or getting medical approval or getting other forms filled out could then turn their wait into another month before getting into care. And you know what happens when you have a month between withdrawal management and getting into care? Well, you go back out and, you know, and I've seen people die in that process while they're waiting, and they go out and they relapse and they die. And that's a serious concern. And there's one thing, you know, that I have to really applaud Dr. Lee for bringing this up, is when somebody's ready to make a change, they're ready right then. It's not like, hey, I've decided I want to quit, and I'm motivated, and something horrible has happened. They're like, yeah, just wait a month, okay, and fill out this paperwork and go over here. Because by the time that comes, I've failed, and as soon as I've failed, I'm right back into shame, and I'm back into hopelessness, and I'm back into something's wrong with me. And then that cycle, once somebody fails once, they fail again, then it's this repetitive pattern of failure, and I'm a failure, I'm not going to work, and this won't work. And when as much as we'd love to, is just to be able to pick people up and say, let's scooch off into treatment as fast as possible. And I think there's a lot of barriers there that Dr. Ken's talking about. Thanks.
Thank you. So, I mean, I think we could talk about this, and we should continue to talk about this for as long as we need to talk about this. what I want to do for the last sort of round is just allow people to share whatever is on their heart, on their mind, anything you thought was really important to share with those in attendance today. Something that you hope people remember going forward, something you hope people do, anything that you just feel called to share with us today, knowing that our intention is to have a better sense of understanding for compassion and connection and prevention and support, and everything we've talked about. So I'll just go with Brennan. You're first to my right there. What would you like us to leave with today?
So just like others, a lot of similarities. What we see working within addictions and trauma, multiple layers of trauma, and probably working together to support the individuals. Like I was saying earlier, that's a lot of work for one individual to do, depending on the intake process, and same thing, the intake. So I myself, I do an Indigenous intake, which is listening. I don't do a whole heck of a lot of talking. And just like it was said, I try to build that rapport and helping that person exude their innate knowledge. They know their own well-being and what they need for themselves as well. And we just try to help them meet their goals and their vision for themselves. So I always get help with my coworkers to help support the individual's needs and goals, and help them with developing a vision if they don't have one already. And I'll give you an example. So I'm in this First Nations community about 3 hours away from London. We were called in for crisis support. So the first thing that was done was a sacred fire, and not by me, but the community. And we worked together to put out those prayers, spirit and intent. And so, for example, instead of name calling, we pray for the individuals that they'll seek the help. They'll be ready to be taught at sooner than later, before it does the end of life. And so that's basically what I want to share today. And I want to thank all the panelists for sharing. I learned a lot myself too. Yeah, I'll go. Big thank you.
Thank you, Brennan. Anyone can go next. Letitia?
Sure. Thank you again for listening. And Brennan, thank you so much again for some cultural teachings there. I really appreciate being able to learn more, because that's what we're all doing. Basically, I would like to see people armed with the ability to ask the hard questions and hold the systems accountable for the desperate change that needs to happen. So if anything you take away from here, I want you to be able to do that in an appropriate way. I want you to be able to hold law and policymakers accountable, to hold programs accountable for feedback and outcomes from the people who are experiencing or navigating their programs. I would like you to be able to talk to your kids about substances in a non-judgmental way that encourages a two-sided conversation based in truth and awareness, not fear and hatred and myth. I would like to walk away from that. I would like you to be able to safety plan with other people in your community and come together as a community to do something rather than sit and wonder what to do, because we all have a job to do. I want neighbors to know each other and be able to see the gaping holes in our system that has piled bodies in for far too long. It's time to end this, and we all have a job to do. And I really want to bring that home. I want you all to see that cuts to healthcare hurt, and they have hurt us for far too long. And there's a better way forward for everybody that helps everybody too. I would like you all to create that change. And even just inside of one person, if we spark just that one little piece of, oh, I see that differently, that's a job well done. So at the very least, I would like you all, whoever is on this call, how many panelists, 101 people, I would like you to go get Narcan training and learn how to clean up a sharp. Those are two things that are incredibly impactful that you can do in your community to be able to do better. And I appreciate every single one of you panelists and the Hive for hosting. This has been really great. Thank you.
Thank you. Thank you for your passion and your commitment. And I think we'll post that after as a call to the community of those who are here now and beyond. And if 101 people can get 3 people to do it, then I think we're going to create huge ripples. Dean, some closing comments, some thoughts, some things you'd like us to take away. If you don't have one, I have one that you mentioned earlier that I'd like.
Yeah, I mean, you can definitely take my closing comment if you like, Jenna. I will second everything that's already been said today, and there's so much wonderful information here. Just a little tiny bit. Each individual and how their addiction develops is just as unique as the person themselves. It's unique as a DNA, it's unique as a fingerprint or a snowflake. And the treatment almost needs to be just as unique. And the way that people need to be treated need to be just as unique. And we're not going to be able to force society into seeing it that way. But I think with the gentle participation over time and making people realize that these are people is the best way that we can do it. And there is no one solution to it. And we need to all work together, because there's this different avenue of saying harm reduction is the right way, or supervised injection, or Suboxone. You know, what is the right way? There is no right way, right? The right way is humanity and kindness and compassion and caring and support and love, education, prevention, all of those great things. Thank you for having me. Appreciate it.
Beautiful. Dean, in our previous conversation, you had mentioned that each one of us lives a life in a way, whether it's our career or our hobbies or the communities in which we are, and all of those places and all of the skills that we have can be used in some capacity to create that sense of support and understanding and community. So just reflecting on where you spend your time and the gifts that you have as a person. Are you a writer? Are you someone who likes to have conversations or gather people? We all have these gifts that come with us that can help to further all the things that we've learned today in our own ways.
Did I say that awesome thing? I guess I did last time we talked. I'm kidding. I'm kidding. Thank you very much, Jenna. Thank you, everybody, for having me.
Katrina, some closing thoughts here.
Yes, I wanted to just echo what some of you have said. This has been really transformative and enlightening for me. It's been so wonderful to hear all of your perspectives and frankly to feel so warmly received for expressing mine. I have never experienced this before, and I'm so grateful. I did write a little paragraph here. I hope you don't mind if I read it, because as this has gone on, I am feeling a little more emotional. So I'll just read this. My hope for what people might get a deeper understanding of is that I hope the people listening will have a better understanding of the complexity of the addiction issue. The crisis isn't just about finding those who are addicted and getting them off of the opioids. The addict is often so much more than just the sum of their addictions and possibly mistakes. The addict usually has a family, is part of a community in some way. No one is an island. Every person connected to them is connected to the trauma that the addiction inflicts. As the child I mentioned, I navigated life feeling attachments to pain, trauma, and abuse. That isn't because I enjoy pain or want to be traumatized. It's because those feelings were very normal to me, and normal feels comfortable to a child. The concepts of love, family, and home were always intertwined with pain, abuse, and insecurity. I learned that I couldn't count on those who loved me to meet my needs. I learned to not trust those who cared for me, and in fact, to not even trust myself or my own feelings. When you combine a lack of trust of oneself, knowledge that one's needs cannot be met, and ongoing trauma and abuse being connected to home and family, it's a recipe for disaster. We, these children, are lucky to make it out alive, but finding a way to avoid addiction ourselves is very difficult. Finding ways to thrive, in spite of having come up in a manner that deprived us of the things we need to thrive, is very tricky. I hope that we will gain a deeper understanding of the holistic way that the family needs to be treated when addiction has traumatized the unit. And that when we talk about the addictions and we talk about the person suffering addictions, we also talk about the circle around them and the people who go on to live with this forever. Even if the person with the addiction recovers, even after that recovery, we need to recover too. And we are a big piece in the puzzle that is this crisis. And thank you again so much for inviting me here today.
Thank you, Katrina. We are also honored that the bravery that you had to share your story with over 100 people, the first time that you have publicly talked about it, is a gift that I think we all really, really feel in our heart. So thank you so much for being here and giving us the lens that is often not seen in the story. Thank you. Dr. Lee, did you have some closing remarks? Anything you'd like to share that hasn't been shared from your perspective?
Sure. I guess the perspective I'd like to make everybody just kind of pay attention to. The people you see who are struggling with addictions that you see on the streets, people who are homeless, people who are, doing things on the corner they shouldn't be doing, that kind of stuff. That may only represent about 1 to 2% of the population of persons with addictions, right? That is not the that is the stereotype, but that's not the true stereotype. There is no stereotype, because if you take the number of 10%, which is widely accepted, and if we have 500,000 people in London, Ontario, in the greater London area, we're talking about 50,000 people. And in my experience, these are 50,000 people that come from all walks of life, all areas of London, rich and poor and middle class, and all employers, all situations, anywhere you go. It's going to be about 1 in 10. So if there's 50,000 people struggling with addictions, hopefully not all at the same time, just be aware that the stereotype you may have coming into this is not the true stereotype of what you should be considering when you're thinking about addictions.
Very important. Dean gave a thumbs up too. I think that was something that I had learned leading up to this event, but it didn't really come up. So I'm really grateful that you did share that. 10% is not in our minds where we think we're seeing these people, but behind closed doors. And that's why we thought it was so important to have this event with as many people as possible, to understand that this is something that could be happening in a closed room in your house and you don't even know. And so to educate ourselves on, a lot of the things that Letitia mentioned, prepare yourself, educate yourself, know how to have these conversations, know how to prepare yourself, even just, Dean's point of think of where you are in society, within the community. If you're a teacher, you have an opportunity to educate children on dealing with difficult feelings and asking for help if they need it. Or, as Katrina mentioned, having being a support for those who don't know where else to turn. And so I think that's a really good landing spot of understanding of how big that this situation is. It is a crisis. That is such a large number of people that are challenged and suffering and are not getting the support, the compassion, the connection that is needed. So before we leave, I want to thank again all of the panelists. This has been so eye-opening. I'm so grateful this is recorded so that we can watch it again, and trying to stay engaged without taking notes, but I definitely want to go through it again. For those of you who are on the call, we will send out an email so you can watch it again as well. Please share this with your network, share it once a week, share it as often as possible so that people can get this information. I want to also thank our sponsors. Those 100+ people that were on the call today would not have been on the call without our sponsors. Thank you so much. We have a platinum sponsor who wants to remain anonymous. Thank you so much for your donation. We also have some gold sponsors. I'll just mention them because they have brought this event to light for so many. Jennifer Slay, Counseling and Coaching, Similam, and Take Back Your Health with Jen Hewson. Our silver sponsors were Power of Her, Jess Jones, Recreation Therapy, Red Dress Stories, Keith Brown, Integration Psychotherapy Services. Our bronze sponsors, Granny Peas, Type Diabetes, and Conditionment Crawford Coaching. So thank you so much. For those of you who have donated, thank you so much. We will be splitting all of the funds received between Sohawk for Brennan and the Nameless for Letitia. thank you. We really can make a difference by connecting with each other, by sharing this information. Please make one commitment to yourself that you will do something after being here today. If 100 people go away and do one thing, and engage in conversations, this really will change the tide of what we've been experiencing. So thank you again on behalf of the Hive. Thank you from Claire as well. She's very grateful for the experience. And we will be emailing you shortly. Thank you so much. Enjoy the rest of your day. Take some time out in nature, take a deep breath, drink some water, and let's continue to stay strong and support one another. Thank you.